So for this lesson, we're going to take a minute and talk about concepts of validity. And if you remember from previous lessons, validity is the ability of the measure or the study to assess what it says that it's going to assess. So what we're looking for here is, does the research article that we are appraising in step 3 actually reach its own stated goals? And then secondarily, how do those stated goals apply to our clinical research question? So our key points here is we're going to discuss about how the unique components of testing human participants make variability a potential threat to the validity of the study, and looking at the difference between internal and external validity. We're also going to look at some of these specific threats from the standpoint of mortality and what that is and how that goes about affecting the validity of the study, and then talk a little bit then at the end about the validity of specific measures as well. So when we talk about threats to validity, we're talking about things that would occur within the research process itself that would create a situation where we would not be able to interpret the results according to the original stated aims. When we talk about internal validity, then what we are talking about is we are talking about the ability of the research conducted to answer the research question. So basically, we're specifically looking at the methods of the research for appropriateness in answering the specific questions. When we get into these threats, what you'll see is a lot of these now are going to be the different components of the methods section, and so we need to evaluate each part of those methods in order to check for appropriateness. And so although we're going to focus on inappropriate aspects, what we need to focus on during our step 3 evaluation is really, can we trust the methods that are presented, and how applicable then in our external validity that we'll discuss second, how applicable are those to then our clinical question? So when we look at threats to internal validity, a lot of this is going to be based off of the fact that we are testing humans, and so we have an increased amount of variation that can occur. The first threat that we classify is one of history. And by history, what we're talking about is the fact that there is often a gap in between testing while interventions occur. If you're doing a longitudinal study over the course of, say, 6 weeks, or we're doing follow-up testing, things are going to be occurring during that time. Our subject participants are not just sitting around waiting to be retested. They're continuing to live their life and do different activities. And those activities then may end up causing a potential problem. And so oftentimes researchers try to limit the amount of external influence by trying to standardize through specific recommendations and procedures that the participants agree to follow regarding what they participate in during their follow-up period. So if you're looking at a strength training study, it might be that we would recommend that those individuals participating not undergo any other form of physical activity, specifically strength training. Also, there might be specific tests leading up to testing, basically saying that if we're looking at strength training, again, we might ask that they eat similar foods, make sure they come to testing well hydrated, so that their body condition is relatively the same between different testing situations that occur over the course of history. Maturation then legitimately has to do with the fact that the human body changes over time. We're constantly aging and changing. And for some groups, that change occurs at a faster rate than others. But irregardless of the rate of change, we have to take into consideration that there are physiological changes that are occurring to the participants in between testing sessions. So we have the possibility that the subjects would actually change physiologically in ways not associated with the intervention or the independent variable of interest. And that would lead to a change not associated with that intervention, and thereby change the ability to interpret those differences between groups. We also have the fact that because we are testing individuals, they always have the right to stop their participation. And so we call this stopping of participation either mortality or attrition, basically saying that there are going to be a certain number of subjects that are going to drop out from the research during the course of the study. Now, that is normal and to be expected, but there's always a possibility that part of the study is then affected by this mortality or attrition. Specifically, those that drop out may end up being of more interest than those that stayed, from the standpoint that those might be the ones that are experiencing either the worst effects associated with that, or might tell us the information on the overall effectiveness of a specific treatment. And so we can only analyze the data from the subjects that complete the entire research protocol. So if we have a high level of attrition in one group but not in the other, we have to think about the fact that is there a possibility that the intervention or the group that was experiencing the high rate of attrition is actually caused by that intervention or by being in that group. If that's the case, it would affect the results of that group in one way or another. If there's a control group that has a large amount of attrition compared to the intervention group, it might be that those individuals in the control group that were not getting any better decided to not participate in the study anymore, thereby artificially increasing the control group's scores, thereby showing that there is no difference between the intervention and the control group. On the other side, if there's a high level of attrition within the intervention group, it's possible that those that are receiving the least benefits from the intervention were to drop out, and thereby artificially boosting the change in the intervention group by only having those remain that are seeing the most benefits, thereby showing a difference between the intervention group and the control group only because the lower performers in the intervention group are no longer within the study. And that's just two examples of ways that attrition or mortality can affect the research study. So as we look through the methods and specifically the results of who completed the study, it's important that we evaluate the number of or the time in between the initial testing and final testing. Basically, what's occurring during that course of the study. Are there potential things that have occurred that would change our ability to interpret the study, whether those changes are due to things that the individuals do outside of the study, as in like a history threat, or changes to the individual themselves, as in a maturation threat, or simply because the groups are no longer the same groups that started, and the possibility that that mortality or attrition has occurred. Two separate internal threats to validity. The first one we talked about previously in the selection or selection bias, this idea that if the sampling technique is wrong or we have inappropriate sampling, we may end up in a situation where the groups are different regarding key variables at the beginning of the study, and thereby making one group more or less prone to change. And so the second thing that we're going to need to look at is what are the scores at baseline of the different groups. First off, if they are too different at the beginning, then we may have a selection bias. Also, if we have large differences and large swings, it could be this idea of regression towards the mean. And we talked about regression towards the mean being a positive when it comes to all of the non-research variables that we're interested in, where we want those to stabilize over the course of time and compared to one group versus the other, so that way they do not have an effect. But if we have a single group or different groups that are performing above or below average on baseline, they're naturally going to return to a more standard component. So you could think about the idea that if we have one group that scores very high on the test at the beginning and one group that scores more average, that group that scored towards the top is probably naturally going to score worse in the second assessment because they simply outperformed their capabilities in the first assessment. And so we have this natural regression towards the mean where we have change not associated with the intervention or of the research study itself, but instead is simply a return to normalcy. So we need to think about, when we're analyzing the baseline assessments, are the two groups similar at baseline in the most important areas? And secondly, right, are they too close to the extremes at baseline? Other threats to internal validity have to do specifically with what is occurring and what is going on within the research itself. And this is the instrumentation and testing or procedures portions of the methods sections. Basically, when you go through and you read these two sections, you're reading about the instruments and testing procedures that the researchers used. This needs to be detailed enough that we have a high understanding of exactly what occurred, as well as that we have the ability to reproduce those if needed in our own treatment approaches. That being said, we also have to make sure that the procedures as well as the instruments meet those reliability and validity assessments that we talked about previously. And so if we do not have reliable or valid procedures or instrumentation, then it makes sense that the internal validity of the research to measure and find the differences that are part of its clinically relevant question would be severely threatened. Some other threats to internal validity that now have to do with reactions of participants during the course of the study have to do with what we normally try to prevent with in bias and with blinding. So there's always the potential for conscious or unconscious bias to occur within the subject population. Since we're assessing individuals, motivation and both conscious and unconscious motivation or decisions regarding treatment or self-care can affect the individuals as well. And this is increased in the setting where the participants or the clinicians or the researchers know what is occurring within the research study and try to either consciously or unconsciously make alterations due to that. So the first one is a diffusion or imitation of treatments threat. And basically what this is if there's communication between the experimental or intervention group and the control group, the participants in the control group might figure out what they're not receiving and try to supplement that in order to improve their own care. So the example that is often used with this, if you find that an intervention that a control group participant finds out that the intervention group is receiving additional strength training exercises as part of their care compared to the control group and their own care, the person in the control group might seek out or do their own exercises on the side, thereby trying to improve their own care. And so the idea here is that if control group members start trying to imitate the treatment group, then they may start to receive some of the benefits of that treatment as well. Now, this can obviously be controlled for in certain areas by just blinding the subjects to their overall control or treatment intervention by either separating them physically or during a course of time where you may have control participants test on even days and treatment people test on odd days or in different locations. You don't want to change too much in between those different groups, but you also do not want to have a situation where they're almost coaching each other on what they're doing. You also may have this idea where individuals try to compensate for the fact that individuals are in a control situation versus a treatment situation. In the case of a clinician trying to compensate for that, they may try to equalize the treatments between the control and treatment groups by providing more effort or increasing the amount of treatment that the control group subjects experience. The idea being that the clinician knows that the control group is not receiving the intervention, and if the clinician believes the intervention may be helpful, the clinician may consciously or unconsciously try to make up for the fact that their patient or their subject here is not receiving what they believe to be the highest form of care by not receiving the intervention. And so in their standard care or in some other conscious or unconscious way, they might increase the amount or the intensity or the motivation that they give to the control subjects. You may also have the control subjects respond in one of two ways, where they feel because they're not receiving the intervention that they want to try to outperform and rival their intervention people. And so they might consciously or unconsciously try harder in their testing to make up for this perceived lack of treatment that they're receiving with less. So they may try to work extra hard on their rehab or on their testing to show that they can, or to try to get better, knowing that they may not be receiving the intervention. The opposite can also occur, where you may have resentful demoralization, where the control participants feel that they have been slighted in some way and begin to feel demoralized or devalued and therefore give lesser effort. Again, these are conscious or unconscious decisions, not saying that this has necessarily occurred, but this is the reason that we spend so much time assessing potential bias associated with blinding. And so when we're evaluating the research articles for its ability to measure what it says it's measuring and predict the differences between groups, we have to be certain that there is not the potential for bias or other alternatives within the methods themselves that could affect those changes. And so when we're reading these, we're looking for the blinding of the participants, the clinician, and the researcher, if at all possible. Now, it's not always possible to do these blindings, but we then have to see if there's any possibility that these interactions or these threats may have occurred. So if internal validity is discussing the threats within the methods of the article itself and its ability to accurately measure and detect changes between the groups within the study, external validity has to do with the ability of the researchers to draw conclusions into different populations than were originally studied. So the threats to external validity will all focus around inappropriate conclusions based on differences between the study that was conducted, as well as then the different populations that might be affected with that. And so these differences can come in a variety of different ways, but the three major ones that are worth discussing are the interactions between the treatment and selection, setting, or history. So basically with this, there are three things that you have to avoid going beyond the results of the study in your interpretation. The first and foremost, and often most inappropriate, is trying to generalize from a narrow population or a narrow sample within a research study to a larger or different population. So if you're studying a research article and they assessed say college-aged individuals, and then you try to make that generalization from that what occurs in college-aged individuals might also occur in an elderly population, you're setting yourself up for a potential external threat to validity, where because the populations are different in a variety of different ways, that those comparisons would be inappropriate. And so we talked about selection of subjects and allocation previously, but that selection of subjects has to do a lot with the validity and the external validity and the ability to interpret those findings beyond the subjects that were tested. And so when trying to make decisions on the applicability of the research that you're consuming and you're analyzing in that step 3, looking to see whether or not you're going to implement it in step 4, one of the big things you're going to have to figure out is whether or not your patient population and the patient population of the research that you're reading is similar enough on the important measures to allow for appropriate generalization from one group to the next. You can also have in research rather specific setting characteristics that may become problematic to replicate in more clinical environments. If you have a very strenuous control trying to maximize the internal validity within the study, that's going to naturally decrease the external validity, because the more we try to control individuals for the research to maximize our internal validity, the more we get away from the natural progression that occurs within normal patient population and patient care. So if we control and do not allow any form of physical activity associated with our individuals in a strength training program, that's going to limit the external validity associated with trying to include a strength training program in individuals that are also physically active. You can also see settings where you may have a specific strength training device that's used in the research, or a specific strength training protocol that's used in the research, and the ability to generalize that from one strength training protocol to another strength training protocol may be inappropriate. So we may have modality specific or implementation specific things to consider. The largest one that often gets put into play is the idea of supervised versus unsupervised rehabilitation. The idea that if an individual receives a supervised program, that they could then do it on their own and get the same results. And because of the differences between a supervised and unsupervised program, regarding the ability of the clinician to intervene if necessary, it would be inappropriate to assume that because a supervised program gets positive results, that an unsupervised program would as well. The last one for external validity has to do with the fact that research occurs at a specific point in time, and generalizing into the past or into the future can become difficult. And the main reasons for this is knowledge and protocols change over time. So the ability to generalize an older research article to the current time frame may become problematic if significant changes have occurred within the knowledge base during that time, as well as at the same point in time to generalize a research article into the future and to make that be the current and end-all be-all for that treatment would be inappropriate. And you only have to look as far as concussion treatment to see how things have changed, and how gaining new knowledge and the deeper understanding of the physiology associated with concussions and their detriments that were unable to be tested previously would make research that has been done in the past inappropriate to generalize to today, because they did not have sensitive enough measures to detect the changes, or the information that has changed now. We know of increased changes associated with concussions over long periods of time, thereby leading to more conservative managements. Also to discuss here, in the last component of validity that we're going to discuss regarding the methods associated with specifically the portions of the tests or the research that we're reading, is statistical validity. And we discussed an introduction of statistics previously. So if you're struggling with this, I would recommend reviewing that lesson as well. But basically, when we look at statistical validity, we have to look at the ability and the appropriateness of the statistics used to specifically find and interpret those differences. The first statistical validity threat is a statistical conclusion validity threat. Basically, when either inappropriate statistics or inappropriate conclusions are derived from the statistics reported. If statistics that are inappropriate are used, any conclusion from those statistics would be inappropriate. But as we talked about in our statistics discussion, if researchers are going beyond the statistics to describe things that the statistic does not do, either by misrepresenting what their p-values are and the difference between significant and clinically relevant differences, or by using descriptive statistics to describe causation, we would then have a threat to the statistical validity of the conclusions to interpret the actual differences between groups. We also talked about statistical power and the importance of having an adequate number of subjects in order to decrease the natural variability between individuals. Another component to consider that's new from our previous discussion is the idea that as you increase the number of statistics that are performed, or the amount of manipulation that occurs within the data, you increase the error rate of those statistics. So if you're doing statistics on previously manipulated data that would not be appropriate, like you're changing the data from the raw data that is the result of the score and then getting and analyzing that compared to the differences, you can get into a situation where errors occur. So the most common example there is specifically analyzing change scores versus raw scores. And so as you if you do a pretest post-test, you can analyze the raw score and the mean between each one, or you can analyze the change between each one. So if the mean for one group is 80 on the pretest and the mean between the in the post-test is 90, and then you compare that to a difference between like 85 and 95, you would see that the differences between the two groups might be significant in the case where they're different at beginning and end, but their change scores would be the same. And so that's a situation where if we analyze the groups beforehand, we would actually get an improvement by running manipulated data. But at that same point, you might get a situation where one group ends up just catching up to the other group, or we get that regression towards the mean. And so you really have to analyze whether or not change score evaluation is appropriate. At the same point in time, there's often times where researchers will run repeated statistics, specifically, like repeated t-tests, or opposed to running more sophisticated tests. And the purpose for running the more sophisticated tests is to test all of that data at one time. When you run repeated t-tests, for example, you increase the probability of an error because you're running so many additional tests that you're more likely to find differences because of the repeated nature of the testing. And then finally, we have the violation of assumptions of statistical tests that we talked about previously, basically where the test is used inappropriately and thereby creates a situation where the value cannot be interpreted. And then lastly, in the statistical validity, it's important to realize that the stats simply analyze the data that has come from the methods that derive the data. And so if there are variability or reliability issues associated with the methods, where the methods are not of sufficient quality to standardize the outcomes, it's important to remember the idea with stats, the whole garbage in, garbage out. Stats are just simply analyzing the data, but if it's not good data to begin with, you're going to have statistical validity issues as well. And so lastly, to review the ideas of validity of measurements that we discussed previously with face validity, content validity, criterion-related validity, and construct validity. These are now the validity of the measures themselves, opposed to simply the methods of the study. And so it's important that research describes the validity testing of the measures that they have used, or at least provides references to do so. And so oftentimes it's important to go and check the validity of the measurements and procedures by reading the source material for those measures to see how accurate those measures are that were used during that and what type of validity occurred. So if you remember, face validity basically is expert opinion. Content validity is the idea of an expert panel suing that, really more in the area of surveys and interviews. And then you have the criterion and construct validity, which you now start to try to compare the instrument to other sources that we know are valid. And so to wrap up, it's important that we realize that because we're analyzing human subject research, there's going to be natural variation within the testing procedure. The goal is to minimize that amount of variability so that the only difference is attributed to our variable of interest. And so when we're consuming this research and analyzing and assessing the research, it's important that we look for the potential problems associated with that variability. Any extra confounding variables or variables that might be creating changes within the differences that are not attributed to the variable of interest would become problematic. It's also important then that we also look at the idea of how we can assess the external variability from one group to the other and how their patient population may or may not be similar to our patient population and how that might be affected, and then understanding the importance to assess the measures themselves.